Hello my geniuses, welcome to another anatomy lecture series today. It's a great science tutor LAWRENZO, and I'll be talking about the elbow joint. In my last video I talked about the shoulder joint, so today we'll be continuing with the elbow joint. So if you have not subscribed to my video, make sure to subscribe and turn on your post notification button so that every time I drop any video you'll be sure to be notified. And if you want me to make a video for you, make sure you drop it down in the comment section. I promise I'll make that video solely for you. And any topics you want, any topic you want me to do for you, you also state it down in the comment section, and once I see it I promise I'll have to do that topic for you solely. So we'll be moving into the steps in elbow joint. So we'll be following our usual outlines on that joint. We'll be following the introduction to the joint, we'll follow the types of the joint, we'll follow the articulating surface, follow the fibrous capsule, follow the synovial membrane, we'll follow the ligament, and so on and so forth. So we'll be doing step by step. So you can use it for your MBBS examination, you can use it for your normal OSCE examinations, you can use this for a USLMA exam. So you can use it for all those stuff. So it will help you because I'll be breaking it down in the shortest easy way for you to understand. So let us jump right to the video. So let's start with the introduction to the elbow joint. First of all, you have to say the introduction. What is the introduction to the elbow joint? So let's take it a little by little. First of all, by what you see, the elbow joint is between what and what? The elbow joint is between the humerus, the lower end of the humerus, and the proximal aspect of the radius and the ulnar bone. Again, is the part of the humerus, the lower part of the humerus, and the proximal part of the radius and ulnar bone. So if it is combining with the proximal part of the radius bone, it forms what we call the humeroradial joint, and if it's joining the ulnar bone, it is formed what we call the humero-ulnar joint. So we have humero-ulnar joint or articulation, and we have humeroradial joint or articulation. So it's very, very simple. So, and where will you see the joint? So number one, take it number one, don't forget, the radial elbow joint is between the lower end of the humerus bone and the proximal side of the ulnar and radius bone. So the proximal side of the radius bone joins with the humerus to form what we call the humeroradial joint, and the proximal part of the ulnar joins with the humerus to form the humero-ulnar joint. So since you have understood that one already, now where is the joint really located? So you can see it about 2 to 3 centimeters just below the line joining the two epicondyli. Again, the elbow joint can be seen. So first one we say it's between the humerus and the radial and ulnar, forming the humero-ulnar and humeroradial joint. That is number one. Two, where can the joint be seen? You can see it about 2 to 3 centimeters just below the line joining the two epicondyli. So the line joining the medial and lateral epicondyle, if you look at 2 to 3 centimeters below, you will see the elbow joint. Are you getting now? So just like the shoulder joint, we say the shoulder joint is between the gluteus cavity of the scapula and the hemispherical head of the humerus. That is the same thing we are saying for this one now. The same thing, that is the introduction to it. So just below the about 2 to 3 centimeters just below the medial and lateral epicondyle. So the line joining the medial and lateral epicondyle just below it. Okay now. So now one thing you have to know, the complexity of the shoulder joint, it increases with what? It increases by 3 different parts. So it increases with the humeroradial joint, humero-ulnar articulation, and the proximal radial-ulnar joint. So first of all, we have the humeroradial joint, humerus and the radius, humero-ulnar joint, humerus and the ulnar, and the proximal radial-ulnar joint. So all this thing we call this what they call cubital articulation. Cubital articulation, because in front of the elbow joint you can see what they call the cubital fossa. So the cubital fossa is in front of the elbow joint. So the complexity of the elbow joint is formed by what? The superior radial-ulnar joint, the humeroradial joint, and humero-ulnar joint. So hope you understood everything I've talked about here. So since we are done with the introduction to the elbow joint, we have done the introduction to the elbow joint. So the next one is the type. So what is the type of this joint? The synovial joint of a hinge variety or a hinge type of a synovial joint. So elbow joint is a hinge type of a synovial joint or a synovial joint of a hinge variety. So it's the same thing, just like the shoulder joint. We say the shoulder joint is a synovial joint of a ball and socket variety, same as the elbow joint is a type of a joint, or is a hinge type of a synovial joint. So now the next one is the articulating surface. What is the articulating surface between the humerus and the what? Ulnar and the radius. So what is the articulating surface? Which part is what? Articulating. So don't forget, it's very, very important for you. So you are seeing the images on your screen. You see the ulnar joining with the humerus bone and the radial joining with the humerus bone. You can see it very well. So now the articulating surface, first of all, the lower end of the humerus have two things. It has a capitulum and it has a what? A trochlear. A capitulum and a trochlear. So the capitulum of the humerus be a part that is joining, the articulating surface being the capitulum of the humerus and the head of the radius. The capitulum of the humerus and the head of the radius. So the capitulum of the humerus will form what we call a humeroradial joint. The capitulum of the humerus and the what? Head of the radius bone. So these form the radio. This one form the humeroradial joint. Now if you go to the ulnar side now, also the trochlear of the humerus articulate with the what we call the trochlear notch of the what? Ulnar bone. So the trochlear of the humerus articulate with the trochlear notch of the ulnar bone to form what we call the humero-ulnar joint. So one thing you have to know that we have two joints. We have the humero-radial joint, humero-ulnar joint. Both of them form the elbow joint. You get it now? So capitulum, head of the radius, trochlear and trochlear notch of the ulnar. You get it now? So and what cartilage is it lined by? So the surface covering of the joint, inside the bones, are covered by cartilage called the hyaline cartilage. So inside the bones are covered by that cartilage. Since they are covered by cartilage, they say this joint is the most congruent when the forearm is in the midway between pronation and supination, and when the elbow is flexed to the right angle. So the joint is congruent when the forearm is midway between pronation and supination, and the elbow is flexed in the right angle. So that is when this joint is much more visible and this joint is much more congruent to each other. Okay, now, so don't forget, again, the articulating surface is between the humerus, which is the capitulum of the humerus, and the head of the radius, and the trochlear of the humerus and the trochlear notch of the ulnar. Don't forget. I get him now. So since you have understood, you are lined by hyaline cartilage, so that is the same thing. So the trochlear resembles a pulley system that allows the movement of the trochlear notch to and fro. So it's acting as a pulley system. That's what contributes to its stability. So since we know, because the trochlear is in the medial aspect of the capitulum, so it just resembles a pulley system, which makes the movement of the trochlear notch of the ulnar very, very easy to move. You get that? So that is one of its stability. So since you have understood this part now, very, very simple. So the next one is the fibrous capsule. So what's the fibrous capsule? So the fibrous capsule here is the non-collagenous connective tissue. Don't forget, non-collagenous dense connective tissue. Now what does it do? It covers the surface of the joint. It covers. So after the joint have articulated, it then covers the surface of the joint. So when it covers the surface of the joint, it provides stability to the joint too. So the first covering of a joint is the fibrous capsule. So where is the fibrous capsule coming from? Above, it is coming from the medial epicondyle. Are you getting now? Up to the lateral margin of the radii, coronoid, and the olecranon fossa. Are you getting now? So in the medial epicondyle, so it's above, attaching the medial epicondyle. So when you attach the medial epicondyle, it now attaches both the upper radii, coronoid, and olecranon fossa. It also covers the lateral epicondyle of the humerus and enclosing the non-articulating fossa of the lower end of the humerus. So on the radii, it covers the medial epicondyle and lateral epicondyle, and the two fossa that are articulating, which is the radii fossa, coronoid fossa, and olecranon fossa. And also it covers the non-articulating surface of the humerus. It is just there. It is just the anatomy. It's just the bone, because now the bone contains opening in the front. The two openings is the radii opening and the coronoid opening. So at the back it has the olecranon fossa. So this thing, it covers those places. So when it covers those places now, also the non-articulating surface too. So when it covers all those places, it comes down below and attaches the anterior and medial margin of the coronoid process of the ulnar. The anterior and medial margin of the coronoid process of the ulnar. And also it attaches the upper margin of the annular ligaments. Don't forget. So first one, you remember, when it comes down, it is attaching the anterior and medial margin of the coronoid process of the ulnar. Anterior and medial margin of the coronoid process of the ulnar, and also the upper margin of the annular ligament, and the upper and medial end of the olecranon process. You get it now? So this is where it's attaching. It's attaching above to the medial and lateral epicondyli, radii, coronoid, or lacrinoid process. Radii and coronoid process is in the front, or lacrinoid process is at the back. So it covers those sides too. Then it comes down, it now attaches the anterior medial margin of the coronoid process, the anterior medial margin of the lacrinoid process, and it now covers the upper margin of the annular ligament. Are you getting now? So when it is attaching downward, it did not cover the radius. So the radius is not part of the covering. It not covers the radius. It only covers the ulnar bone majorly, and upper it connects the medial and lateral epicondyle. Are you getting now? So medial and lateral epicondyle. So this is very important because it facilitates movement both in the anterior and posterior axis, called flexion and extension. So that is the reason for covering, and it provides stability. It provides stability. So the next one is the synovial membrane. Inside this joint capsule now, I'm telling you a story. So we have done about the introduction. We have given you the type. It is a hinge type of a synovial joint, or a synovial joint of a hinge variety. So we have done the articulating surface between the humerus and the ulna, and between the ulna and the radius, lined by hyaline cartilage. So these joints joints emerging upwards in the humerus and downwards in the ulna. The radii do not participate in it, providing stability and allowing flexion and what extension. So inside this joint capsule, inside this fibrous capsule, we have a lining called the synovial membrane. So that lining is called the synovial membrane, which secretes what? Synovial fluid. So that lining has synovial membrane, which secretes synovial fluid, which allows joint fluidity, allow movement of the joint in flexion and extension. So anyhow the joint want to move, that synovial membrane prevents friction between the bones. So because without the synovial membrane, there will be no nourishment to the joint, and anytime the bone is moving, what will happen? It will be cracking, or there will be pain. I get him now. So one, the hyaline cartilage lines there, and inside the fibrous capsule you have a synovial membrane lining the fibrous capsule and the joint themselves, secreting synovial fluid forward. Movement. Are you getting now? For movement of the joint freely. Okay now. So now the joint capsule is what? Is weak anteriorly. So don't forget. So the joint capsule that attach from up to down is weak anteriorly and posteriorly. You get it now? So it is weak, but it's much more top by the side. So by the side is attached, but front and back are very weak. Are you getting that? Because that's where ligaments are more attaching. So the only thing that covers the front and back is joint capsule. You get it now? But at the side you have ligaments. So first thing after the articulating surface is the joint capsule. After the joint capsule, ligaments comes. So that I'm just giving a typical vision of how joints are covered and protected and to provide stability. Because so many things, when we do the stability, so many things that contribute to stability of a joint. So joint capsule, ligament. So after joint capsule covering the joint, a joint capsule, after a joint capsule is covering a joint, the next one is the ligament. So we are telling you now that the ligament is only side to side, medial and lateral side, but it's only a joint capsule that is covering front and back. You get it now? So we have talked about introduction. We have talked about the type, we have talked about the articulating surface, we have talked about the fibrous capsule, we have talked about the synovial membrane. So we are moving into the ligaments. So what are the ligaments here? You get it now? So the ligament, we have the radial collateral ligament and the ulnar collateral ligament. The radial collateral ligament and the ulnar collateral ligament. So hope you are following me now. So I told you we'll be following an outline that will help you. You get it now? The outline is so important for you to follow. So the radial collateral ligament, where does it extend? So it extends from the lateral epicondyle, I get him now, down to the annular ligament of the radius. So again, the radial collateral ligament, or you call it the lateral collateral ligament, anyone you want to call it, it begins from the lateral epicondyle and is attaching distally to the radii, and attaching distally to the annular ligament of the radius. You get it now? So you can see it on your screen. You see the annular ligament, you see where it is coming from. You get it now? It's coming from the lateral epicondyle, and it comes and it attaches to the annular ligament. You get it now? For the ulnar collateral ligament, or we call it the medial collateral ligament, it's extending from the medial epicondyle, just like the radial collateral ligament is coming from the lateral epicondyle. So when it begins from there, what does it do? It's attaching to the lacrinoid process, and it's also attaching to the coronoid process of the ulnar. I get him now through what we call 3 bands. So it has 3 bands that attaches to the what olecraноid process and also attaches to the coronoid process. So what the 3 bands are anterior, posterior, and inferior. So 3 bands. The 3 bands are the one anterior, which is strongest and the most stiffest. You have the one posterior, and you want the one what inferior. 3 bands. So, but one thing you need to understand that both of them are coming from the medial and lateral collateral ligament. But the radial collateral ligament, both of them are coming from the medial and lateral epicondyli. That's one thing you have to understand. So one thing you have to understand that both of them are coming from the medial and lateral epicondyli. But the radial collateral goes to the annular ligament, while the ulnar collateral forms 3 bands that attach to the coronoid and on the olecraноid process. So we have understood that part now. The next thing that we'll be going to is what is the relations here. So what is the relation? So simple. So the relation is that what muscles, what vessels can we see passing through different places. The first one that we'll be talking about is your anatomy, because if you go to my video on muscles of the arm, you see where the muscles are going and where they are inserting to. So in the anterior part, what is there? In the anterior part, what is there? In the anterior part, we have what we call the brachialis muscle. So remember MBBS. Remember MBBS. So MBBS is the content that passes through the cubital fossa. The content that passes through the cubital fossa, MBBS. This also provides what anterior relation to the what elbow joint, because the floor of the because the floor of the cubital fossa is the elbow joint. So the cubital fossa, vessels, muscles, and all of them of the cubital fossa are anterior to the elbow joint. So go watch my videos on the cubital fossa. It's very, very important. It's an important anatomical space. Don't forget. Content of the cubital fossa, MBBS. MBBS. The content of the cubital fossa is the anterior relation of the elbow joint. So MBBS, the median nerve, the brachialis muscle, the brachial arteries, and the tendon of the bicep brachii. But here, the only difference that is not here is the what we call the superficial branch of the radial nerve. It is not here. You get it now? So it's the content of the cubital fossa, but it's not among. You get it now? Because it branches and go to the back of the to supply the forearm. Yeah, it goes to the back, so it is not directly in front. So immediately it leaves the cubital fossa, it goes into the back of the forearm to innervate the posterior compartment of the forearm. You get it now? So the only content here is the medial nerve, the brachialis muscle, the brachial artery, and the bicep tendon. Yeah, now. So that is another thing. So now the next thing is the posterior. So what can you say posterior? Posterior, naturally, the insertion, because the tricep passes through the to insert on the what we call the olecranon process. So when it passes through that place, it is passing the elbow joint. So it marks the posterior boundaries of the elbow joint. So we have the tricep brachii and the anconeus. So the anconeus too insert there too. Okay now. So the anconeus also and the triceps mark the posterior relation of the elbow joint. So the anterior relation is MBB. B, just continuous. MBBB, medial nerve, brachial artery, brachialis muscle, bicep tendon. While posterior is tendon of the tricep, tricep tendon and the anconeus. So in the medial now, what can you see there? You are seeing all these write-ups on your screen. Are you getting now? So most of them has been taught in my other playlist video, so you can go back there and watch them. So you get it now. So we have the medially now. What can you see medially? Remember, in my muscles of the anterior compartment of the forearm, if you go there and watch it, you see all of them are originating from one place called the medial epicondyle. We call it the common flexure origin for muscles of the anterior compartment of the arm. Common flexure origin for muscles of the anterior compartment of your arm. So the anterior compartment of your arm is when you supinate your arm. When you supinate your palm, your forearm now, the anterior compartment that helps you flex the forearm. It helps you flex the forearm. Also help you in gripping. So that muscles in the anterior part of your forearm, that is where they are originating. So that marks the medial boundaries of the elbow joint. Also, your flexor carpi ulnaris. Yeah, your flexor carpi ulnaris is also among your muscles of the anterior compartment of the forearm. So let's continue now. So we have the lateral now, who is coming from lateral. The same thing. If common flexure muscle of the anterior compartment of the arm is coming from the medial side, again, common flexure muscle, the origin of the all common flexure muscle, that is the anterior compartment of the arm. PFPFF, I gave you. PFPFF. Pronator teres, flexure carpi radialis, palmaris longus, flexure carpi ulnaris, flexure digitorum superficialis. PFPFF. And we have PFF. The last one, PFF, which I give you, is your pronator quadratus, flexure pollicis longus, and flexure digitorum profundus. These muscles are in the anterior compartment of the arm. So now for the laterally, now we have the common extensor origin for the muscles of the posterior compartment of the arm, at the back of your forearm. At the back of your forearm, that's where you see this muscle. You know the difference between your anterior and the posterior part of your arm, of the forearm. So you know the difference between the anterior and posterior part of the forearm. So that is one thing you have to know. So it's very, very important. So since we know that is the lateral, you can also see flexure carpi radialis. So we also have extensor carpi radialis brevis is also part of it. So it's also part of it. So but they are also under muscles of the what? Forearm, posterior part of the forearm. You also have the supinator. The supinator muscle also is there. All of them are inside the extensor muscle at the posterior compartment of the forearm. So at the media, you have the common flexure muscle, all the muscles of the anterior compartment of the forearm, they are originating from there. And you have laterally, you have the muscles of the posterior compartment of the forearm coming from the other side. You get it now? So we have said this one, we have said all these things up down to the relation. The next thing is the bursa. So what is the bursa there? So bursa is just free space below the muscle. It's just a free space below the muscle that allows the movement of the joint. So it doesn't allow the muscle to like have friction with the bone. So it doesn't want the muscle to be tightly to the bone or to have any friction with the bone part. So you just allow the muscle to move freely. So that's the usefulness of a bursa. So a bursa is very important because it helps the muscle move freely on the bone. So it doesn't want that doing when the muscle is moving freely to be scratching the bone and causing inflammation. So that's why bursa are good. So the bursa here, we call it what they call you have the first one, subtendinous or lacrimal bursa. So don't forget, subtendinous or lacrimal bursa. That's the first one. Then you have your subcutaneous or lacrimal bursa. Don't forget, subcutaneous or lacrimal bursa. So this is one bursa that is here. So you have the subtendinous bursa, you have the subcutaneous or lacrimal bursa. You also have some bursas here also, which is the biceptoradial bursa, and you have the bursa separating the bicep tendon from the oblique ligament. But the key bursas here are the subtendinous or lacrimal bursa and the subcutaneous or lacrimal bursa. Don't forget, subtendinous or lacrimal bursa, subcutaneous or lacrimal bursa. So you also have others like the biceptoradial bursa and the bursa between the bicep tendon and the oblique cord. Just like the name, subtendinous bursa, it is the bursa between the tricep tendon and the upper surface of the lacrimal process. Subtendinous, under the tendon. Subtendinous, under the tendon. The bursa under the tendon. So the subcutaneous or lacrimal bursa is between the skin and the subcutaneous triangular area of the lacrimal bone. So between the skin and the lacrimal bone, subcutaneous or lacrimal bursa, and the subtendinous or lacrimal bursa is between the tendon, which is the tricep tendon, and the lacrimal process. Between the tricep and the lacrimal process is the subtendinous, and between the skin and the lacrimal is the subcutaneous bursa. Are you getting now? So subcutaneous, subtendinous. You get it now? So now the next one we'll be talking. So we have talked about the bursa. So we have the SS, which is the major one, the subcutaneous and subtendinous bursa. I'm giving you the relation. The relation, don't forget, anterior relation. Content passing through the cubital fossa. Posteriorly, we have majorly the tricep and the anconeus. In the medial side, we have the common flexure muscle that passes through, or that are for the anterior compartment of the arm. They are originating at the medial epicondyli, which marks the medial relation. And we have the lateral side, which is the common extensor origin, which is the muscles of the posterior compartment of the forearm. You get it now? These are muscles that are both the superficial and deep. You get it now? So don't forget. So now we have the stability. How is the elbow joint stable? How is the elbow joint stable? It's so key and so important. It is stable because one, muscles that passes there contribute stability to the joints. Don't forget, not only some particular parts. So any muscle that passes through there keep the joint so firm and stable, because without those muscles passing there or attaching there, what happens? The elbow joint in high trauma can dislodge and spoil. So this muscle also contribute to helping it to stay calm and not to damage. Also your ligaments, so your ligament prevent excessive movement in the two directions. Remember, we said that the joint capsule only covers the anterior and the posterior. The joint capsule covers the anterior and posterior. So the anterior and posterior part of the elbow joint is weak. Don't forget, anterior and posterior part of the elbow joint is weak, but the medial and lateral side is very strong. Why? Because of the radial and ulnar collateral ligament. The radial and ulnar collateral ligament. Repeat it to yourself. Everything I'm talking about, pause it and repeat it to yourself. So first of all, muscles contribute to stability. The medial, the radial and ulnar collateral ligament contribute to stability, preventing for excessive movement in all directions. And also the particular part that I want you to know about this elbow joint is that the particular part that I want you to know about this elbow joint is the pulley system of the trochlear. I told you before, the trochlear acts as a pulley system, which makes the trochlear knot fit into it 100%. So the trochlear, remember, the trochlear of the humerus articulate with the trochlear notch of the ulnar. So but the trochlear of the humerus acts as a pulley system to allow the trochlear notch fit into it, so that provides stability 100%. So the trochlear acting as a pulley system, muscles and the ligaments. Hope you are understanding this. This is the part that contributes to stability. So simple, it's not hard. Get it now? So what is the blood supply here? Very, very simple. The blood supply here is also the elbow anastomosis. The elbow anastomosis is between the brachial artery, the ulnar and the radial artery. The brachial artery, the ulnar and the radial artery. The radial what? So the elbow anastomosis. The elbow anastomosis is between the brachial artery, the ulnar and the radial artery. So you go watch my video on the elbow anastomosis. So now the nerve supply here. What is the nerve supply? Some nerve, any nerve that passes through any joint gives a supply to that joint. Any nerve that passes through any joint gives a supply to that joint. So the first one we're talking about is the radial nerve. So the radial nerve pass and go posteriorly, so it gives a branch to there. The musculocutaneous nerve also come down, supply muscles of the arm. Musculocutaneous supply muscles of the arm and continues as the lateral cutaneous nerve of the forearm. The musculocutaneous nerve passes through the musculocutaneous nerve supplies the muscles of the arm. After your shoulder is your arm, so it supplies muscles of the arm anterior compartment and becomes the lateral cutaneous nerve of the what? Forearm. Okay, now so he also give a branch to the elbow joint. The radial nerve that supply posterior, the triceps and the conconeus, also give a supply to elbow to the back of the give a supply to the elbow joint. So you also have the ulnar nerve, you also have the medial nerve. These nerves also pass through that area too. Very simple. So any nerve that passes to any joint give a supply to that joint. So the musculocutaneous nerve passes there, the medial nerve passes there, the radial and ulnar nerve passes there. So all of them will contribute and give a function to that joint. So the next one is the movement. So what movement can we see here? The movement is so sweet. It has only two movements, unlike the joint with the ball and socket, which is the hip and the shoulder. The hip and the shoulder have 6 movements, but the elbow and the knee have 2 movements. So what are the 2 movements? You have flexion and extension. Flexion and what? Extension. Flexion and extension. That's why there's a joint capsule to allow movement like that. For flexion, we have key muscle. What is the chief muscle that allows flexion? The chief muscle that allows flexion is the brachialis muscle. So the brachialis muscle is a chief muscle for what? Flexion. So the brachialis muscle allows what? Flexion. So after brachialis muscle, who are the people? You have a brachioradialis also, BBB, don't forget, BBB. Brachialis, brachioradialis and bicep tendon. Brachialis, brachioradialis and bicep tendon. Don't forget. So the chief muscle here is the brachialis muscle. The chief muscle is the brachialis muscle, but sometimes the bicep brachii can also be, but the bicep brachii assists in supination. So since it passes through the joint, since any muscle that passes through any joint will give a function to that joint, so which means the bicep passes through the bicipital aponeurosis, also makes it possible for there should be flexion of the what elbow. Are you getting now? So in the absence of others, in the absence of those two, the brachioradialis can also produce rapid flexion. So the brachioradialis is a muscle of the posterior compartment. The muscle of the posterior compartment that's supposed to extend, but it is not extending, it is doing what? Flexion. So it always do flexion when bicep and brachialis is out. So when bicep and brachialis is out, the brachioradialis will pick up normal what function. But I told you that the brachialis and the pronator teres assist in flexion. Don't forget, pronator teres and brachialis assist in what? Flexion. So now for extension of the elbow, who extend the elbow? The chief extensor of the elbow is the tricep. So the tricep breaker is the chief extensor of the elbow. Who is assisting? The aconius. The aconius assist in flexion. The aconius and the tricep assist in extension, while the bicep brachii, brachialis, and what? Brachioradialis assist in what? Flexion. You get it now? So it is very important you should know that there are total of 17 muscles that crosses the elbow. All muscles majorly crosses the elbow. 17 of them crosses the elbow. Are you getting? Extend from to the forearm and then to the hand. Are you getting now? So it's not all of them that give function to the elbow. No, there are many, especially muscles of the medial, muscles of the anterior compartment of the forearm, and muscles of the posterior compartment of the forearm. You get it now? Anterior is about how many? 5 and 3, which is 8. Posterior is about 12. So there are plenty that passes. Yeah, now there are plenty that passes, but it's only 3 for the front that give us flexion, and 2 for the back that give us what? Extension. And now to know that when you extend your elbow, extension of the elbow, what happens? Now the epicondyli, the two epicondyli and the Lakenon process are in the same line. When you extend your elbow, your two epicondyli and your Lakenon are in the same line. But when you flex your elbow, your Lakenon process are in right angle, like they are triangular with the epicondyle. So if you try it now, flex your elbow, you see that your Lakenon process is forming a triangle with the two epicondyle. But when you extend, your Lakenon is on the same line as the two epicondyle. So don't forget. It's very, very important. It's very, very important. So now what you have to know is the clinical correlation. So we have so many clinical correlation. First of all, we have joint effusion. So what is joint effusion? Are you getting now? Joint effusion. For there to be joint effusion, there's inflammation. So inflammation forms abnormal fluid collection there, which we call what we call edema. Are you getting now? So this is when there's distension of the elbow joint due to what? Effusion within the cavity. So when there's abnormal fluid packing up there during inflammation, maybe any part of the joint has it obliterated. So when it's obliterated, fluid will pack there, and when fluid pack there, what happens? It will be difficulty in movement because the fluid will tighten the joint very well and you'll be feeling pain. So how did they work on that? They use a needle, they aspirate the fluid away. Are you getting now? So the joint is aspirated by inserting a needle posterolateral side above the head of the humerus at a right angle. So when you put it posterolateral side above the head of the humerus, you can aspirate the fluid away. Are you getting now? So again, the next one is dislocation of the elbow. Dislocation of the elbow. How is the elbow dislocated? The elbow is dislocated posteriorly. Are you getting now? The posteriorly is the most common part of dislocation. Are you getting now? So if there is posterior dislocation of the elbow, there will not be fraction of the what? Coronoid process. So there is always posterior dislocation of the elbow because of it is not really that strong, because there's what we call a hard end feel when you are going back. There's a soft end feel when you flex your arm. Soft end feel means when you flex your tissue of your forearm meets your arm. Your tissue of your forearm, the anterior part of your forearm meets your arm, so it's a soft end feel. So when you extend, you feel that grab sound, which is the hard end feel. So which means it can dislocate posteriorly. Are you getting that? Also, there's also fracture of what we call the coronoid process. The fracture of the coronoid process when you fall with your hand being what? Outstretched. When you fall with your hand being outstretched. And I told you that when you extend your hand, your Lakenon process is on the same line as your epicondyle. But when you flex your hand, what happens? They are in a triangle. You get it now? They are in what? Triangle. So we also have tennis elbow. So what's tennis elbow? Is very, very important. Tennis elbow is when there's inflammation to the lateral, the common extensor muscles originating from the lateral epicondyle. to cause what we call lateral epicondylitis. Lateral epicondylitis, inflammation of the common extensor muscles originating from the lateral epicondyle. So this occurs when there is too much extension. So when you are extending too much, that there will be irritation of the muscles on their origin, on that bone. So when there's irritation, there will be inflammation, and that inflammation can cause wear or tear around the origin of that muscles, and this will cause what we call pain and tenderness around the lateral epicondyle. Remember, what originates from the lateral epicondyle? Muscles of the common extensor origin, so which is originating for the posterior compartment of the forearm. So when they are originating from the excessive extension over time, causes what? It causes inflammation. There will be a thrust around the muscles on the bone. So if there's a thrust, inflammation will occur. There will be tenderness, there will be pain, there will be edema around that area. Are you getting now? And the pain is usually felt during abrupt pronation. When you want to pronate your hand, you always see that pain. Are you getting now? They always see that pain, and it is occurring due to what you used to call, what event I told you, excessive extension should be. You sprain it. So when you sprain your lateral collateral ligament, you also see that, because your lateral collateral ligament protects that area. You can also see it. Now when there's a tear in the extensor carpi radialis brevis, the extensor carpi radialis brevis is the first muscle originating from there. So when you sprain that one, it can cause that problem. And when there is the inflammation of the bursa underneath the flexor carpi radialis brevis, you also see. You get it now? The bursa around there is also infected. And also when there's continuous wear and tear of the common extensor, that is the key. When there's continuous wear and tear over that area. Now if you turn it to the medial side, now there's what we call medial epicondylitis, but we see it called the golfer's elbow. So this is golfer's elbow. So there's a tennis elbow and there's a golfer's elbow. Tennis elbow is for the lateral epicondyle due to continuous wear and tear of the common extensor muscle of the forearm, their origination in the lateral epicondyle. But now the golfer's elbow is for the medial epicondylitis, which is inflammation or irritation of muscles around the origin of that place. So the medial epicondyle is the marks the origin for the flexion muscle. So when there's excessive wear and tear there, or there's a damage of the medial collateral ligament, or there's inflammation in the bursa around that area, it can cause pain, tenderness, difficulty in flexion. But if it's for lateral epicondylitis, it's difficulty in what? Extension. Why? Because golfers use that part very well. They always flex their hand when they shoot out the ball. Those that play golf, so they are all usually having that condition called medial epicondylitis. Now we also have student elbow, or we call it miner's elbow. Student elbow or miner's elbow. Are you getting now? This one too is also an inflammation. Are you getting now? When there is an inflammation in the subcutaneous olecranon bursa. So the subcutaneous olecranon bursa is between the skin and the olecranon bone. So when there's inflammation around that area, it also causes the same thing: pain, swelling. Pain, swelling, that place will be red also, and there will be tenderness to palpitation. So that's the student elbow. Student elbow, subcutaneous olecranon bursa. You get it now? So I hope it all made sense to you, and you have gotten everything I've talked about in the elbow joints. It's very, very simple. Go around, look at everything I've taught you in the elbow joints. So simple. I talked about the introduction between the radius bone and the ulnar and radius. And I talked about in the introduction the elbow joint is between the humerus, lower end of the humerus, and the proximal part of the ulnar and the radius. Very simple. You get it now? So it forms what we call a humeroradii and humero-ulnar joint. You get it now? So I also talked that it forms a congregation between the humeroradii, humero-ulnar, and proximal radiocarpal. So I talked about the type being that it is a hinge type of a synovial joint, or a synovial joint of a hinge variety. I talked about that. So I talked about the articulating surface is lined by hinge hyaline cartilage. I talked about the ligament, ulnar radial collateral ligament. I talked about the movements, BBB in front. BBB helps in flexion, and what TA helps in what? Extension. TA, triceps and acromius, don't forget. Anterior relation, we say it is muscle that passes through the cubital fossa, except from the superficial branch of radial nerve. Posterior, triceps and acromius, the same thing. So I hope it all makes sense. Hope you understood everything I've talked about. The picture is there, the wordings are there. Read it up and understand what I've said. and you get it now. So you see that you always appreciate everything we have done for you. So please should push it to every student that will need this, because this is used for medical examination and for you to understand really about the elbow joint. So I'll be seeing you in my next video. Which is the muscles of the wrist joint. So we have done the shoulder joint, this is the elbow joint, and we'll do the wrist joint. Bye bye.